Welcome. It's so nice to see such a tremendous turnout. My name's Sandy Jansen, and I am Vice President of Patient Care and Risk Management here at St. Joseph's Healthcare. And honestly, seeing all of your faces and some familiar faces, people from the past and people that I've not met before, it's been such a lovely evening so far. So welcome to our DocTalks lecture. We have what I think is going to be an amazing presentation for you today. Dr. Sheri-Lynn Kane and Dr. Elliott beside me are going to share with you some information that is important and probably most importantly, very relevant to our lives today. Who is here for the first time? Wow, welcome. Welcome. It's so great to see new faces here at DocTalks. And for our regular attendees, and I spoke to many of you earlier, welcome back. We're so pleased that you do continue to join us. I hear that this is quite an event, and I hear that tickets for this are harder to get than Taylor Swift. Is that true? That's what I heard. So I know that in addition to attending our St. Joseph's events, I know that many of you are donors to the care, education, and research that we provide here at St. Joseph's. And I really want to thank you for your generosity and your kindness, because it's through your commitments that you support St. Joseph's to invest in specialized research and care that impact you and your families and our entire community. So thank you very much for your ongoing support of St. Joseph's. Please give all of you a big round of applause. Now, is Adrian from Chartwell here? No, darn, I wanted to meet Adrian. I haven't met her yet. But I wanted to let you know that our 2024-2025 DocTalks lecture series is sponsored by Chartwell Retirement Residences. And I really want to give Chartwell a huge round of applause as well. And if Adrian was here, we'd be really celebrating her. So Chartwell is Canada's leader in seniors housing. And if you take a look at Chartwell, I just love it. I looked at this today. What they say is they're all about people. And at St. Joseph's, we're also all about people. They support health, happiness, and peace of mind for older adults and their families and the communities across this country. They have many, many diverse residences, and they offer flexible support and care options to meet the needs of older adults today. So I want to thank again Chartwell for their ongoing and incredibly generous support of this event. So let's do another round of applause. So as I mentioned tonight, we are so privileged to have Drs. Sheri-Lynn Kane and Jacobi Elliott here presenting today. But before I hand the mic over, I wanted to share a little bit about them. So Dr. Kane. Dr. Kane is a geriatrician, the chair of the Division of Geriatrics here in London. She's also an associate professor of medicine at Western University's Schulich School of Medicine and Dentistry. She serves as the medical director for the Regional Geriatric Program of Southwestern Ontario, as well as the chair of the Provincial Geriatrics Leadership Ontario Steering Committee. Sorry, what do you do in your spare time?
Meet with you.
Okay, yeah, that's right, we meet, that's right. So as a geriatrician, Sheri-Lynn provides care for older adults in inpatient setting, outreach, rehab, and clinics. And she is very committed to improving the healthcare system for older adults, and especially those older adults experiencing frailty, both now and into the future. We also have with us Jacobi Elliott, who again, Jacobi's level of energy, Jacobi has, when I read this, you're gonna say, how has this woman figured out how to have more than 24 hours in a day? Because it's absolutely incredible what Jacobi has accomplished. So Jacobi is a director of research and strategy for the Regional Geriatrics Program of Southwestern Ontario, which, by the way, is hosted by St. Joseph's Healthcare London. Jacobi is an early career researcher who I think has probably accomplished more than many late career researchers, but an early career researcher who holds positions as a scientist at Lawson Research Institute. She is an adjunct professor. She has adjunct professor roles at Western University and the University of Waterloo. She has more than 10 years of experience in consulting and conducting research across the healthcare system. Her research focuses on care transitions, patient and family engagement, and the geriatric healthcare system challenges that we face today. This blows me away. She has published more than 35 published papers related to health systems research. There are over 35 papers. That's incredible. I think I published 2. And I'm a little older than you are. So anyways, just incredible. What was I going to say? Right. These 2 women, I have the privilege of working with pretty much every day. We probably chat pretty much every day. And quite honestly, they are among the 2 most brilliant women that I have had the privilege to interact with. But better than that, they're just amazing human beings. So with a shared passion for care of older adults and a goal to reimagine the future of that care, they're here together to present a presentation called Fostering a Healthcare System Responsive to Older Adults. So ladies and gentlemen, please join me in welcoming Doctors Sheri-Lynn, Kane, and Jacobi Elliott.
Okay, can everyone hear me okay in the back? Good, okay, perfect. So thank you again so much for having us this evening. As Sandy so kindly introduced us, I'm Jacobi Elliott, and I'll be presenting alongside Dr. Sheri-Lynn Kane this evening. We are here tonight to talk to you about fostering a healthcare system that is responsive to older adults and their caregivers. We would first like to start off by acknowledging our many colleagues and partners. We cannot do this work alone. We would like to acknowledge the members of the Regional Geriatric Program Research and Strategy Team, the many healthcare partners across the region, and the many older adults who have contributed their time to this work. Dr. Kane and I would also like to acknowledge our colleague, Erin Watson, if you want to stand up and give a little wave. Erin works alongside us as Director of Clinical Operations for the Regional Geriatric Program. And we would also like to acknowledge the leadership of our executive sponsor, Sandy Jansen. Okay, so we would really love to know who we have in the room this evening. So in a moment, I'm going to get you to do a show of hands, but we know many of you may wear multiple hats, so feel free to raise your hands as many times as you want. So, do we have any caregivers in the room? Anyone that identifies as a family or friend caregiver? Okay, what about a working caregiver? Those that are trying to still maintain their working lives and provide care as well, a few of you. What about patients with complexity or patients with multiple chronic conditions? A few people. Any other researchers in the room? Seen one up there, yes, thank you. Any healthcare providers? A few healthcare providers. And any health system leaders? A couple of you as well. Great, a great mix of people here this evening. So we know that our population is aging, and by 2030, which, if you can believe it, is only 5 years away from now, there will be almost 500,000 older adults living in Southwestern Ontario. This is a 20% increase from our current population, so really a rapidly growing segment of our population. And 25% of older adults will be considered complex or living with multiple chronic conditions. And these individuals typically use more healthcare services. Throughout our presentation, we will be referring to the term complex older adults or older adults living with complexity. So what do we mean by this? These are individuals who have multiple chronic conditions. The average individual around 65 years of age has about 4 chronic conditions, and around 75 years of age has about 5 chronic conditions. As you can see on the screen here, as an individual ages, they're more likely to have more chronic conditions. Again, these individuals with more chronic conditions are more likely to use healthcare services, more likely to see multiple healthcare providers, and visit multiple different healthcare organizations. We can't talk about our aging population without highlighting family and friend caregivers and the significant role that they play in supporting our older adults. There are more than 4 million people in Ontario providing some level of care or support to a family member, friend, or neighbor. And 66% of these individuals are balancing employment with their caregiving role. So let's think about that. People are trying to work while also providing a significant amount of caregiving time. We know from recent data that caregivers are feeling more burnt out and are increasingly providing more care and support due to health system challenges, resource shortages, and lengthy wait times to access services. Across Canada, caregivers are accounting for 5.7 billion hours of caregiving, which is equivalent to $97 billion in time spent in their caregiving role. In Ontario, this is about $30 billion of caregiving time. So again, a significant contribution that our caregivers are making to our healthcare system. There are a number of current health system challenges, and we wanted to highlight just a few for you this evening. Over 84,000 residents in Middlesex, London currently do not have a primary care provider. So they don't have access to a primary care physician or a nurse practitioner. That's about 16% of the Middlesex, London population. I'm sure it's no surprise that there are lengthy wait times in our healthcare system, including wait times for geriatric services, home care services, wait time for surgeries. There are over 45,000 people waiting on a wait list for a long-term care bed. That's more than double the number of people that there were 10 years ago. And on average, people wait about 2.5 years to access a long-term care bed. These numbers will only continue to grow as our population ages. And lastly, there's a significant health human resource shortage across the system, meaning longer wait times for services, or in some cases, services may even close. Additionally, we know that people working in the system aren't always trained in geriatrics. So not only do we have a health human resource shortage, those that are working in the system may not be trained to support our complex older adults. So I've briefly highlighted some of the current state of aging and caregiving in Ontario and some of our current health system challenges. We now want to share what we're doing locally to support the healthcare system for our aging community. St. Joseph's is the host of the Regional Geriatric Program. Between 1988 and 1992, the ministry funded regional geriatric programs across the province. These are centered around our academic hospitals and medical schools. So we have the Regional Geriatric Program of Southwestern Ontario here in London, hosted by St. Joseph's. There's a Regional Geriatric Program in Hamilton, Toronto, Kingston, Ottawa, and Northern Ontario. And RGPs are responsible for enhancing clinical excellence in the region, promoting capacity building and education, capacity planning, conducting innovative research, and supporting our advocacy efforts. The Regional Geriatric Program of Southwestern Ontario, again hosted by St. Joseph's, covers the Southwest and Erie-St. Clair region. So essentially from Windsor to Stratford is the geography that we cover. We have a strong leadership model with Director of Clinical Operations, Director of Research and Strategy, and a Medical Director. We also have a research and strategy team made up of quality improvement and evaluation consultants and researchers that work with partners across the region to improve the system with the goal of enhancing experiences for patients, caregivers, and providers. We also have a number of students and trainees that work with us, and we have developed strong partnerships across the community and with academic partners to help us carry out our mandate. To further address the health system challenges and guide the Regional Geriatric Program, we have formed a Regional Executive Steering Committee, which includes a group of senior leaders and physician leads from across the region, representing different sectors of the healthcare system. So hospital, community care, primary care, specialty care, long-term care. This group comes together every few months to discuss any barriers to achieving our work and to help support our vision across the region. We have our local regional geriatric program based here, as I've mentioned, but we're also able to collaborate and learn from the regional geriatric programs across the province through the Provincial Geriatric Leadership Ontario group. The PGLO leadership brings together the RGP leads monthly to share lessons learned and collaborate together. This is also an avenue for advocacy efforts. For example, Dr. Kane raised the issue about the lack of respite beds available in our region and across the province for caregivers who needed a break. This concern was brought forward to PGLO. PGLO gathered additional evidence and information. They then advocated to the ministry. And recently, we have seen an increase in the number of available respite beds in our region because of these advocacy efforts. I'm now going to pass it over to Dr. Kane, who will talk about some of our current initiatives.
Thank you, Jacobi. So before I talk about some of the clinical initiatives that we have, I wanted to actually talk about what is specialized geriatric services. This is something that unifies all of the clinical initiatives that you'll hear about and essentially the core of what we do. So the comprehensive geriatric assessment is actually the technology of specialized geriatric services. And it's essentially an assessment that will evaluate someone under each of these domains that you see: medical history, function, cognition, as listed. And with this holistic information, we're able to make diagnoses and put together a patient and family-centered plan and help to execute that. So that's our technology. Here's just a few of the initiatives that we're proud to share tonight. So the Falls Fractures and Frailty and Mobility Clinic, we call it the 3FM Clinic. And this has been born out of the work of many people. I'd like to especially highlight, though, Doctors Jaspreet Bangu from our Division of Geriatric Medicine and Janelle Unger, who's from the School of Physical Therapy at Western, for the work that they've done pulling this together. And why is a falls and fractures clinic important? That may seem like a very obvious question, but falls, and especially injurious falls, are a major threat to older adults, and they come with considerable costs both to the individual and to our healthcare system. So this clinic is a fully integrated research clinic that actually uses the comprehensive geriatric assessment that I explained, together with the assessment of the interdisciplinary team, to be able to look at the underlying causes for falls for that individual and help to remediate and rehabilitate those causes to try and reduce future risk. And in order to reduce fractures, you obviously need to know about the strength of the bones and to assess and treat that. And so osteoporosis assessment and management is also embedded in this clinic. And what's really exciting about this clinic is I had mentioned that it's an integrated research clinic. So we have students from Western Health Sciences as research assistants working alongside with our clinicians right in the clinic. And I can tell you that, the reason I'm a geriatrician is directly related to an opportunity I had, and because this is being recorded, I will not say how long ago, working with Dr. Keith Hayes at Parkwood. And it was that experience that just turned me right on to the field of geriatrics. So not only is this clinic providing excellent clinical care, advancing research, but hopefully inspiring the next generation of students to consider going into the health professions or becoming a healthcare researcher. Our Oxford County Nurse Practitioner Clinic was something that was created in an attempt to get better access and to decrease the burden of traveling for our people on the wait list for clinics in London who live in Oxford. And we worked together with our excellent nurse practitioner, Lauren Gardner, and nurse Leah Barnes, and they would do assessments of people in Oxford, in their home or at a local clinic, and then they would consult with one of the geriatricians as needed for support. The pilot was evaluated and more than met the aims of the project, and now this project is fully integrated as a permanent program. So the nurse-led outreach team is another project I wanted to tell you about. And the Ministry of Health actually collects very detailed data about the time and reason that an older person living in long-term care may need to access the emergency room. And how many of you have been to the Emerge in the last 6 months, either yourselves or with a loved one? I know I have. So I'm sure you can attest to it being not always an easy experience. So imagine if you're 88 and you're there alone and you have dementia. The emergency room can be a very difficult place to be, a very difficult experience. So this project, and we've been happy to participate in it. The ministry has actually supported the growth of initially a pilot project that we ran through the Regional Geriatric Program. This has allowed people to be assessed and cared for in long-term care. And very fortunately, we just received funding to expand this program.
So another pillar of the RGP focuses on innovative research and system evaluation. So here at St. Joseph's, in partnership with Lawson Research Institute, we focus on 4 key areas of aging research: dementia, delirium, falls and mobility, and healthcare systems. So I wanted to highlight just a few research projects that we currently have underway right now. St. Joseph's has been the leader in dementia research for over 30 years, under the leadership of Dr. Bory, Dr. Wells, and Dr. Montero Odasso. The team is part of the Canadian Collaboration on Neurodegeneration and Aging and has led multiple successful research initiatives. Currently, Dr. Bangu is leading work focused on assessment and early diagnosis of dementia through the identification of biomarkers. This work aims to have a significant impact on the accuracy of diagnosis and allows for more personalized care management plans. A second research study we are leading is focused on Behavioral Supports Ontario. BSO is a provincial initiative that provides services for older adults with complex and responsive behaviors, usually associated with dementia. These services are provided in the community and in long-term care homes. We are interested in understanding the current experiences with BSO from the perspectives of caregivers and healthcare providers. We want to know what's working well and what isn't working well, in an effort to make some system improvements to enhance experiences and outcomes for the residents and the caregivers. Over 300 surveys have been completed and 30 in-depth interviews have been conducted, and we're just in the process of analyzing this data, and the results will be shared with leadership and Ministry of Health partners. And another example of health systems related research is a project funded by the Canadian Institutes for Health Research. and it focuses on better understanding patient and caregiver experiences throughout care transitions. We know that older adults transition throughout the healthcare system, visiting different sectors, different organizations, different healthcare providers. And care sometimes breaks down during the points of transition. Poor transitions leads to poor patient experiences, increased risk of hospital readmission, and increased risk of visiting the emergency department. We are interested in learning about current experiences as people move between hospitals and back to the community in an effort to create smoother processes. This research is being conducted at 3 hospitals in Ontario. This is just a very small snapshot of the research that we do through Lawson Research Institute and the Regional Geriatric Program. The research we do is made possible by donations and by external funding agencies. And I'll hand it back over to Dr. Kane to talk about a case study and wrap up with some key takeaways.
So I wanted to be able to share just a couple kind of clinical vignettes with you that might resonate and leave you with hopefully some practical suggestions and tools. And I wanted to look at the whole issue of needing extra support or supporting others, both before a crisis, during a crisis, and after a crisis. So the example that I'll give is 2 daughters who are trying very hard to adhere to their mother's wishes to remain in her own home. Their mother has moderate Alzheimer's dementia, and she does need help with most kind of daily activities. She gets up at night. She lives alone in her home, and she gets up at night. They're worried about her falling, and every measure they try to put in place is met with some, let's say, resistance. So what can we do? And again, this is a specific case, and I wanted to leave you with some tools. So not everyone knows about the Ontario Caregiver Organization. And you can go on their website. First of all, they have a chat line 24 hours. They have a hotline you can call. But they also have a toolkit. And you can pick, caring for someone with dementia, someone with mobility difficulties. You can pick what area you're interested for more resources. And there's wonderful videos, short videos that provide education for how you can improve what you're doing to try to help someone or yourself. And I can't say enough about education and support. Certainly in the area of dementia, we know that support and education of older adults does more to help the individual person and their caregiver than any medication that we have. That is shown in studies, and that's where the Alzheimer's Society does a great job of trying to provide that support and education in various formats that's accessible to people. I think before a crisis, it's very important to kind of know your local resources. And so, more and more we have access, with permission always, to the tests that are done and electronic medical records. People always have access to their own records through health records at a hospital. We now have something called Connect My Health. And that's a portal in Southwestern Ontario that connects over 23 organizations, including labs and diagnostics. It's free, so you can sign up for this service both for yourself and you can help someone else that might require assistance to sign up also. So that's called Connect My Health. It's really important to know about Ontario Health at Home. That's the new name for Home and Community Care, which is the name before the Lynn, which is the name before CCAC. So home care, essentially. Ontario Health at Home is the name of it. And it's very important to know your case coordinator or the case coordinator of the person that you're trying to assist. And so their name is important to decrease frustration. If you could get an extension or an extension of their assistant, that just makes it easier when you call. Because the Ontario Health at Home is the gateway to some of those support services in the home. There's also something, and I have a few referral forms here, but it's the London Middlesex Community Support Service Network. And it's basically a one referral, one-stop shop for anything that Ontario Health at Home doesn't do. So for instance, transportation services, Meals on Wheels, some of the in-home cleaning programs. There's lots of support and education that you can access through this group too, friendly check-ins. So that's also a great resource to link up with. Yeah, sure. So it's the London Middlesex Community Support Service Network. And I've got some referrals here if you would. And it's also in our handy brochure. Thank you, Jacobi. It's in there. I'm glad for that. Yeah. It's also very handy to know the medical team and to have the extension and name of secretaries. Secretaries are wonderful people in time of in need. This is a document I wanted to bring your attention to, both the website and the QR code if you're interested, called the Contingency Planning. And this basically alerts you to the information that would be required in the event of a crisis. All the information that's going to be very helpful to you. And it's just kind of logs it in one spot. And maybe if you thought, oh, I didn't think about that. It's a really nice document to do when it isn't a crisis. I see in my work people that don't know who their power of attorney for personal care or finances. They don't know where the documents are. The people who are power of attorney didn't know they were, which is quite problematic at a time of crisis. So it's just really helpful to have that kind of established and in place and accessible. I think expanding the circle of care is something that's very important. And whether that's family, extended family, neighbors, faith communities, if people can be asked, so many people just want to help, they don't know how. If they're just asked and said, you know, we would really appreciate if you could X, Y, or Z. Or within your family, like who are the people that can do what? And just being really clear about that. And what is the communication plan? How are we going to communicate together? I'm going to talk about self-compassion and care more than once because it's hugely important. This is hard work. And we don't get it right all the time. And we just have to forgive ourselves and keep trying. I also talk every day about what's plan B. So if this isn't working, what is plan B? Because it's very difficult to develop a plan B in the moment, in the heat of a crisis. That's the worst time. So being able to think through and to start to put some things in motion for, I call it the safety net, an insurance policy. I say, well, you know, you hope you never have to use it, but if you do, you're sure happy that you have it. And we will talk more about that. And then the discussion and documentation of advanced care wishes I'm going to speak about. This is another area. Often people have worked a lifetime, they've paid into their benefits, and people don't think, oh, maybe there's something, if someone's fortunate enough to have coverage or benefits, something that we could maximize. You've paid for it. And if you are trying to assist someone, you can, again, always with permission, request to attend their appointments. And that could be in person and virtual. The government is really trying to ensure that people have access to care, and virtual care is a big part of that. And virtual care can be a telephone on speaker. I do that all the time in my clinic. So who needs to do advanced care planning? We all do. We never know when we may be faced at any age with a situation where we cannot speak for ourselves. And I'll tell you, people who have done this work, which isn't really that much work, it's just we always put it off, it is a gift to your family. It's an absolute gift, because in a crisis, when they're being asked, they're not guessing, they're not agonizing, they know because you've talked about it. And this is a great resource for being able to kind of walk through the discussion, which is a nuanced discussion. And this resource is wonderful for helping and documenting, and then you've got that document too, okay? So during a crisis, a couple living together, he has Parkinson's and has some dementia associated with his Parkinson's. He falls. The two of them were managing just fine until she fell, broke her arm, and then couldn't care for him or her. And their only local relative is a niece who has a job and a family and is trying desperately to help them. This is again where we have to ask. People hate asking, I understand that, I hate asking, but people also more like helping. And so if you can actually just ask some very specific, concrete, helpful things, maybe it's the drive to the appointment, maybe it's picking up groceries, maybe but people love to help. And this is in a crisis when you have to ask. Have those powers of attorneys at hand and all that great work that has been done in the advanced care documentation. Whatever you've collected in one place in terms of previous records. I was actually just dictating a note today, and the person's wife had arrived with everything itemized. It was wonderful. It's lovely. It's very helpful. And then I see this, because I work in acute care also, I see at a time of crisis that family arrive en masse. And I understand that, but crises are rarely short-lived. They tend to go over days and sometimes longer. And so it's really important for the person in the crisis that the visits are spread out and coordinated. And so that person doesn't have 6 people around their bedside at one moment and then no one for the next 23 hours. And it's also a lot easier because caregivers they're spelling each other off and getting rest. It may be necessary to supplement the public system with private support for a period of time to get through that crisis. You have to keep advocating. This is the hard work with those people that you've already had on speed dial. And this is when Plan B may need to be put in play. And the way I think about Plan B is nothing is ever set in stone. So if we try and it doesn't work out, then you rethink what different plan? What's Plan C? Because sometimes the forever nature of Plan B is what has people say no. But sometimes, look, it's a crisis. We're just going to try this for now, and we'll see how it goes in a month. And after a crisis, so that's when it's time to update files because things may have changed. And I think that is a perfect time to review advanced care wishes. Sometimes when you've been through a scary health event, your perspective changes and your wishes change. And it's important to talk about that. You know, we've talked about caregiving being hard, but caregiving is also for a number of people that I see an amazing sense of worth and purpose. And sometimes when that, heavy caregiving is over, people feel a bit lost. And if something hasn't gone right in the journey, sometimes people also feel quite angry. And so my suggestions there would be, please share your experience. Every hospital has a patient relations or a patient experience office. It can be in phone, it can be in writing, it can be in person. I've met with lots of people after the fact. And then the Ontario Caregiver Organization has that opportunity to share experiences also. And I'm going to go to the last point because, again, there's enormous purpose and meaning in getting involved when you then feel you have the time and capability. And we have amazing patient and caregiver advisory group at St. Joe's that do work alongside with us, to be trying to improve our system. And their voice is as important as anyone else's at the table. The Alzheimer's Society is also a great way with, experience to be able to kind of give back and share what you've learned with others who are struggling. And I'll say self-care again at the end because I find that during a crisis, people neglect their own health. And so it's really time to take stock of your own health and do all those things for you that you've needed to do for a while but have been putting off. So a few takeaways. The age demographic graph that you saw, those people are living with complexity. It's only a quarter of the older adult population. I always turn that around and say the good news is 75% don't. But those people are a major part of the healthcare system and will be for decades to come. And despite all of our efforts at the system levels, patient and caregivers need to think and plan and advocate for care. I think that patients and caregivers are an enormous strength to our system and need to be engaged in that system improvement or we won't get anywhere. The Regional Geriatric Program of Southwestern Ontario is trying to bridge silos, I hope that you could see that, across both geography and sectors. That's the big area. And to provide as best as we can equitable access to care. We are committed within the Regional Geriatric Program to evaluation of initiatives so that we know, what we're trying. Is it working? Is it working for the patients and caregivers? And then we will continue to participate in and lead innovative research. And we thank you for your participation in that. Thank you.
I want to thank Sheri-Lynn and Jacobi. Amazing presenters, don't you think? And these are... I can tell you there is hope in the system, and you're looking at it right now. So thank you to Sheri-Lynn and Jacobi. We're so fortunate that we can lead this work in London, and we're fortunate because of people like you and donors like you that contribute to St. Joseph's. You allow us to do the work that we do every day. I want to once again thank Chartwell Retirement Residents for supporting our DocTalks series. This is our final DocTalk for the calendar year, so we won't be having one before Christmas. But mark your calendars, because I know it's hard to get tickets. February 5th, Dr. Cindy, I can't say Cindy tonight. What does that say about me? I don't know. Okay. Dr. Cindy Hutnick, who's our citywide chair chief of ophthalmology, is going to be presenting a presentation called The Silent Thief, How to Protect Your Eyes. What do you think that's going to be about? Sunshine, maybe? I don't know. We'll see. We are in the process of finalizing our topics and dates for our next series of DocTalks, which will start in April 2025. And hopefully at that February 5th session, we'll be able to share more information with you. I have a question for our first-timers today. Are you going to come back? Excellent. And for those that have kept coming, are you going to come back? Awesome. Well, thank you so much for joining today and for those fantastic questions that really got us thinking. And I hope everyone has a safe and healthy Christmas season. Thank you.